All right, so we are talking about the kidney today. We're going to go through all the roles that it plays in filtering, in urine concentration, reabsorbing, secretion, all the different things that the kidney can do. So we'll start here with filtration. So the kidney receives about 20% of our blood supply, and it comes in up here through the top, and it goes into our kidney, and all of the molecules, you'll have glucose, water, ions, amino acids, lactate, things like that. They're going to get filtered into the kidney, and these are going to be based on pressure, size, and charge. But like I said, nearly everything that meets these requirements are going to be filtered into the kidney, and then we don't want to lose all of those things because all those things are very valuable to our body. So we have processes that help reabsorb from the kidney back into the blood, and these are very specific to different ions, to water, to glucose, amino acids, things like that. So the first step, filtration, reabsorption. We can actually have secretion, which is just the opposite of reabsorption, and that's where it goes again from the kidney from the blood into the kidney. And once again, that's very specific. And then after we've done these processes, it's excretion, and excretion is where it goes out in the urine. So I'll just scoot this up a little bit. Kind of, again, we talked about things that are filtered: glucose, sodium, water, chloride, potassium, calcium, amino acids, lactate, and then HCO3, that's bicarb, that will play an important role in acid-base balance here in the future. Some things that we can talk about, we'll talk about the membranes that contribute to filtration, and you'll see why we should never see large proteins, why we should never see red blood cells, white blood cells, platelets in the urine, and I'll talk about that. So flip the page. I have drawn here, this is a very simplified Bowman's capsule. We have an afferent arteriole coming in. We have exchange here. We have an efferent arteriole exiting, a little different than other capillary systems you've seen in the body because it has an efferent arteriole instead of a venule. But I want to talk about going from here in the glomerulus, these glomerular capillaries, into the Bowman's capsule. So we have a couple different layers. We have fenestrated endothelium. This is going to be along the inside of the capillaries here. There's going to be pores and negatively charged glycoproteins that are going to contribute to the filter. So anything that's small or bigger than a pore, than one of these pores, and these are about 70 nanometers in diameter. Anything bigger is going to be filtered out. For reference, red blood cells are about 7,000 nanometers in diameter, and so that's why you can see that we should never have red blood cells that go through the kidney and are excreted in the urine. These negatively charged glycoproteins are going to repulse negatively charged proteins that are big. Anything that's big and has a negative charge, these glycoproteins are going to force away. There's another, this is made up of 4 layers, a basement membrane. So it's going to be, once again, kind of right here in this capillary. It's going to have pores, and it's going to have, once again, negative proteins. This is very charge specific, prevents filtration from large negatively charged molecules. It's important to note that HCO3 and chloride, these are small, they're going to go through. Podocytes, these, because of the pressures that are in the glomerulus and the arterioles in the glomerulus, they would normally burst at that high. That's about 55 millimeters of mercury, whereas a normal capillary is about 25 millimeters of mercury. And so there's these specialized cells that kind of wrap around these capillaries that kind of prevent them from blowing apart. And these are the podocytes, and they have finger-like processes. So you can think of my fingers here kind of wrapping around an arteriole and really holding it so it doesn't blow. But there's gaps that form between these finger-like projections. So you would see these gaps like here, and they would have filtration slits that are formed by, I believe it's negatively charged proteins, and they filter out based on size and charge. It's pretty selective. And then there's mesangial cells. These are similar to smooth muscle in the fact that they have the ability to contract, and they influence filtration by regulating intercapillary flow. They also provide structure to the glomerular capillaries. Just like we have in regular capillaries, we have a couple different things that are going to affect it. We have hydrostatic pressure, so that's going to be blood pressure. We have BCOP. We have hydrostatic pressure of the capsule. We don't have an ICOP. You'll remember ICOP from before, and that's the solutes in our interstitial space, and that's because anything that comes in here is going to get taken down the nephron, and it's going to be processed either to be reabsorbed or excreted in the urine. So just like we talked about in our capillary regulation, we have, like I said, we have hydrostatic pressure. That's going to be about 50 to 55 millimeters of mercury. And our arteries, there's some different ways that it can regulate this to keep it at about 50 to 55 millimeters mercury. We also have about 15 millimeters mercury hydrostatic pressure pushing back into the artery. So that's would be, I guess you could say, a negative pressure for diffusion. And then the BCOP, this is our blood colloid osmotic pressure, is going to be pulling back into the capillary as well. So when you do the net filtration math, you come out to about a net filtration of 10 millimeters of mercury. And it's important to remember that we also don't have lymphatic systems in the kidney. So once this gets into the kidney, we have about 10 millimeters of mercury pushing into the kidney. That's what's going to start our process for filtration, reabsorption, secretion, and excretion. It's important to note that this is auto-regulated, this system here. The afferent arteriole, if you think about it, if we have low blood pressure in the body, this afferent arteriole can dilate. So your body, it's called a let me think. It's the tubuloglomerular reflex. So there's cells here that they can detect. They can detect the concentration of sodium and chloride in the ascending tubule, and if that concentration is low, they will signal for more flow into the capillaries, and they're going to do that via nitric oxide. Nitric oxide is a vasodilator. It's going to vasodilate this afferent arteriole, and that's going to allow an increase in pressure to reach that 55 millimeters of mercury. There is also, if we have too much blood pressure, we can what's called a myogenic response. That's, remember, these blood vessels are lined with smooth muscle, and so when they stretch, smooth muscle has a stretch-induced constriction via mechanically gated calcium channels, and this reduces blood flow to the glomerulus via afferent arterial vasoconstriction. So that works great for high blood pressure, but for low blood pressure, you have to have that juxtaglomerular complex. Also, with the juxtaglomerular complex, you can have vasoconstriction of this efferent arteriole so that you can increase the pressure in here as well. And like I said, that's from the macula densa cells. They monitor the sodium and the chloride in the filtrate. One thing to add to that, if they have higher, I'll flip this over so you can see it, just notes here. If there's higher levels of sodium and chloride in the filtrate, we'll see a release of ATP, which is metabolized to adenosine, which normally you would see adenosine as a vasodilator, but in these blood vessels, it's a vasoconstrictor. It all just depends on the type of receptor that it interacts with. And it just so happens that the receptors in the glomerulus allow for vasoconstriction. All right, so we've talked about filtration. We need to talk more about absorption. So I'll talk about that now. So there's different parts of the kidney. There is the proximal convoluted tubule. There is the distal straight, or the proximal straight convoluted straight tubule. So proximal straight tubule. There's the descending tubule, the ascending tubule, the then the distal tubule, and there's a couple different cell types in the distal tubule, and we'll go over that in a minute, but we'll start closest to the glomerulus. So basic things for reabsorption, we have I'll just show you really quick. Transcellular, so this is going to be through the cell, and paracellular, this is going to be in between the cells. So we'll start in the proximal convoluted tubule, and this is probably the most important part for reabsorption. You can see I have listed here, we have 70% of sodium chloride gets reabsorbed here, 70% of water, 100% of glucose, 80% of bicarb, and 100% of amino acids. So it's responsible for resorption of the largest fraction of filtrate. It relies heavily on secondary active transport established by sodium-potassium ATPase pumps. And you can see those throughout the kidney, throughout the whole body, but throughout the kidney, that's what's going to be establishing this gradient. And once it's in the blood, it's going to be taken away. So this gradient is continually going this way, especially for the sodium. So we'll start with these easy cells, these easy transports. These are co-transports, like I said, relies on this gradient for sodium that wants to come into the cell, because it's also established by this sodium-potassium pump here that's pulling sodium out of the cell and bringing potassium in. So sodium wants to come in, so we have the filtrate over here. We have sodium co-transporting lactate, sodium co-transporting glucose. This is the SGLT2 protein that's transporting it. And then we have sodium co-transporting amino acids. Glucose is going to come over here. It's going to be taken into the blood. I believe this is a GLUT2 protein. I didn't write it down, but I believe it's a GLUT2 protein. In between these cells, you'll see that we do have capability for water to come through here. When water does come through, it will pull along calcium, potassium, it can pull along chloride, it can pull along sodium in what's called a solvent drag. It will just drag those ions through the spaces between the cells. On the other side, on the basal side of the cells, we have sodium. This is going to once again be working into its gradient. There's not a lot of sodium in here, and we're going to use a co-transporter for our sodium amino acids or lactate. That's going to get, once again, 100% of those amino acids and lactate back into the blood. We also have potassium leak channels that's going to be going back into the blood. We have aquaporins in this that's going to be coming into the blood as well. Do you remember water is going to follow salt. So we have water following salt as we have sodium, especially, and some calcium, potassium that are coming back in the blood. So 70% of the water is going to go through into the blood at this point in time. Remember, this is transcellular, this is paracellular. One thing with sodium leaving this, it's going to leave the lumen out here. It's going to leave it more negative, and that's going to drive resorption of negatively charged molecules as well. And you can think of this at this time, the lumen and the tubular fluid are pretty much isoosmotic, and that's because we don't have a restriction on water. We don't have a restriction on we have a little bit of restriction on different ions, but water, because water can go where salt is, it's going to be essentially isoosmotic. There's not going to be a huge change in the osmolarity of the tubular fluid and the lumen. Down here we have a couple more that we need to talk about a little bit. Bicarbon hydrogen, we have a transporter up here that's going to take hydrogen. It's going to antiport sodium, so sodium is going to come into the cell. It's going to take hydrogen out of the cell. Hydrogen will interact with HCO3 to form H2O and CO2. This will react with carbonic anhydrase, and it will go in the cell. H2O CO2, it'll turn to HCO3 and a hydrogen ion. Then we can get HCO3 reabsorption into the blood down here, and also HCO3 resorption into the blood up here, and we're excreting hydrogen ions into the blood. There is a secretion that occurs here. I apologize, it's so small. This is important for penicillin. So when they first discovered penicillin, they learned that it was not very long lasting. It didn't have a very long half-life. And so they found out that it has a transport that pretty much takes it out the first round. I think it was like 70% is filtered out as it goes through the kidney, and it goes through via this alpha ketoglutarate, penicillin, PAH protein. Once again, it's established by the sodium potassium pump. So we have sodium bringing in the alpha ketoglutarate, and then the alpha ketoglutarate coming out, penicillin coming in, and the penicillin is getting pumped. This is an ATP getting pumped into the lumen. And so what they did is that they came up with a competitive inhibitor, I guess you would call it, that competes with this penicillin. So if you have something that's competing with this, your penicillin is going to stay in the system longer. So that's an important tidbit of information when we're talking about secretion, especially with penicillin and other drugs. Okay, we covered the proximal convoluted tubule. Let's go to the proximal straight tubule. You can imagine we reabsorbed a lot of sodium in that last section. It leaves us with a high concentration of chloride, a high concentration of hydrogen ions in the tubule fluid. So with this one, we'll go through this as well and make sure you can see it well. Once again, we're going to have aquaporin channels, so water is going to be following salt still. We have this NHE3 channel. Once again, we're going to be following the sodium gradient. It's going to contribute to this cycle here. So hydrogen will be pumped out into the tubular fluid. It will combine with the base, and it will come back in. It will separate, the base will come down, and it will be pushed out, and a chloride will be brought in with the CFEX channel. And then on this side, we have chloride and potassium, and they're going to be pushing out potassium's with its gradient, The chloride will also be with its gradient. There's leak channels also for potassium and chloride, and once again everything's set up by this sodium potassium ATPase. We still have the ability for water to go paracellularly, so we're going to get some solvent drag as well. That's pretty much it for the proximal straight tubule. You'll notice that as we continue to go down further and further, these don't have as many important roles to play. They're still important, but they don't have as many transporters in each cell. So the descending tubule, you've probably heard of the loop of Henle before. The loop of Henle consists of a descending tubule and an ascending tubule. The descending tubule is responsible for concentrating and diluting fluids in the filtrate. So basically, we're going to have water, and water is going to go from the tubular fluid to the blood, still following salt. 15% of water reabsorption. So right now we're up to about, I believe 90%. Let's see here, 70%, 15, so about 80% of water is reabsorbed at this point. So we're going to flip back over. We're going to go to the ascending tubule now. This is responsible for salt reabsorption. The big thing here is this is not permeable to water, so water can't get through, transcellular or paracellular. I've drawn these gates here, and it says that it is closed to water. You're not going to get water going reabsorbed into the blood during this time. But we are going to get reabsorption of different ions. We have this NKCC2 channel, or pump rather. It's going to pump a potassium, 2 chlorides, and a sodium. You'll remember we saw this in the ear, in the stria vascularis, to create the potassium gradient for the basal cells in the ear. I'm pretty sure they're called basal cells in the ear. Anyways, that's the same pump. It's down here in the kidneys as well, and it's going to take these ions and it's going to put them back into the cell. Then we have channels for potassium, we have channels for calcium, we have HCO3 chloride channels, so we're getting bicarb reabsorbed into the blood. We're getting hydrogen, it's going to be being kicked back out into the lumen, and once again water is not coming through here. Interesting thing here, we have drugs that will inhibit this NKCC2 channel. And if you inhibit this NKCC2 channel, you will have a more concentrated fluid in the tubular fluid will be more concentrated. It will actually want to draw more water in as soon as it gets the opportunity to do so. And when you have more water in, you're going to excrete more water. So you'll think that these drugs are what's called a diuretic, and you probably heard of diuretic before. And that's what they do. They're water pills, a lot of people will call them. So bumetanide and furosemide, they are the two diuretics that will act on this NKCC2 pump. All right, we're going to keep going. We're making it out. We're in the distal tubule now. We're going to divide the distal tubule up into a couple different segments. There's the early distal and the late distal. The early distal will have macula densa cells. These macula densa cells, the way that this tubule is positioned right near the afferent and efferent arterioles and the glomerulus, the macula densa cells are able to communicate, kind of like we talked about earlier. We had those different responses, the juxtamedullary response. That's going to be, the macula densa cells are going to be a part of that. So it's taking a sample of the sodium chloride concentration of the lumen here, of the tubular fluid, and depending on whether it is more concentrated or less concentrated, it will send signals to the afferent arteriole or the efferent arteriole to either vasodilate or vasoconstrict, whether it needs increased pressure or decreased pressure to get an increased concentration of sodium and chloride in the tubular fluid. Once again, this is impermeable to water, so water is not going to pass. So you can think of this, if this is blocked, we're going to have a saltier tubular fluid. And once again, there's some drugs, thiazide. You'll also know that that's a diuretic. It blocks this NCC transporter, and sodium chloride would be stuck in the tubular fluid, and it would cause an increase in water as soon as water is permeable to the kidney, to the nephron at that point. So we're coming down here to the late distal cells. We have principal cells and intercalated cells. Right here I have drawn principal cells. Principal cells are a little bit different. They are going to be controlled with hormones. You've heard antidiuretic hormone. I've talked about it when we were addressing heart rate and blood pressure. And now we're going to talk about it, how it works down here in the kidneys. So this ADH, if it is released, if we need our blood pressure to increase, our ADH will go through the renin, angiotensin, aldosterone, ADH cascade. And we get down here and we finally get ADH release. ADH is going to come in. It's going to bind to this G protein right here. This G protein will dissociate and we'll have a alpha unit, I would imagine, come down here, and it's going to interact with this vesicle that contains aquaporin channels. And when it does interact, these aquaporin channels are going to find their way into the basal and apical. So apical is here, basal is here, side of the cell, and it's going to allow water through the cell and back into the blood. All right. Let me talk. I need to find it really quick. We'll talk about the intercalated cells, and then I need to pause really quick to get where I need to in my notes. So here we have intercalated cells right here. We have a type A and a type B cell. These cells are for acid-base regulation. I remember at type A cell, acid to the collecting duct, type B cell, bicarb to the collecting duct. You could also say base to the collecting duct. We have type B and type A. So in situations where we have elevated hydrogen ions in the blood, we're going to want to get those out into the lumen. So what we will do is we will, let's see here, we will have these cells here are going to use ATP to push hydrogen out. We're going to use an antiporter, that's an ATP antiporter, to push hydrogen out and bring potassium in. And then potassium is going to go to the blood. And then we'll have HCO3, which bicarb, going to the blood. That's going to help buffer the increased hydrogen ions. And with this, it's important to remember that when we have a low pH in the blood, when we're acidic or have high concentrations of hydrogen ions, we will also have high concentrations of potassium ions, and part of that is due to this cell right here. There's also other mechanisms. When you have high potassium in the blood, you will have a swap in your cells, a potassium. Essentially, it doesn't work directly, a potassium for hydrogen, but you'll have end result a potassium that goes into the cell and hydrogen that comes out, so you'll have more acidic, and you'll try to be clearing those out. And it's just the opposite over here. This is going to, if you have basic, you're going to have bicarb that's going to be going to the collecting duct. So this is going to be active during alkalosis, this one. And this, you'll have a risk of, like I said, you'll have a risk of hypokalemia. This one is going to be active during acidosis, and you'll have a risk of hyperkalemia, hypo. So I'm going to stop there. I'm going to get some notes organized, and then we'll finish off. Okay, just want to touch on a couple things that I missed as I've been reading over the requirements for this essay. I'm going to talk about GFR really quick. GFR is glomerular filtration rate. And what that can tell us is basically how many, the rate of a certain particle that is being excreted in the urine. And we have to find a molecule that's neither resorbed or secreted. And so they found that inulin, not insulin, inulin is neither resorbed or secreted, and it's used as an indicator for GFR, and it's kind of a gold standard. But there is kind of complications because you'll have to have large amounts of this either injected. I think, honestly, injected. I don't think you consume large amounts of inulin to where you would find this in your excretion. But creatinine is very close to inulin. I'll pull it up here from the bottom. Creatinine is very close to inulin, and it can be used for an estimated GFR. And this you don't need to have specialized testing for because it's always in your body. You're constantly making it at a constant rate, and you either reabsorb it or secrete it. So you filter it and you excrete it. So we're able to measure our GFR, our estimated GFR, based on creatinine clearance, and this is between 88 to 137 milliliters per minute. And so that's a GFR. A GFR above 100 is good. If you get down below 100, you're starting to see some issues with the kidney. If you get down further, you're going to start seeing kidney failure, dialysis, things like that, where your kidney really needs help. There's a couple things that should be completely reabsorbed. We talked about this when we talked about the proximal convoluted tubule, glucose, amino acids. These things should be completely reabsorbed because our body needs them for function. And so if we are seeing any glucose in the urine, we know that our glucose-specific resorption proteins are being saturated. And the only way that they're going to be saturated is if we have too much glucose in the blood. And if we have too much glucose in the blood, we know that our body is not uptaking glucose. And we know that to be diabetes. So the renal threshold for transportation, it will become saturated and the substance is excreted in the urine. I believe this saturation, or I believe that the kidneys are able to reabsorb. Oh, I wish I had it. I think it's 200 milligrams per deciliter of glucose. Anything over that, you're going to lose glucose to the urine, and you're going to have some signs of diabetes, and you'll probably have to go and talk to your doctor and see if you can get things worked out. So let me pull this up really quick. GFR, we talked about that. We talked about clearance. We can talk about the loop of Henle really quick. I don't have it drawn out. I have it maybe in this other book really quick. Let me see if I have it drawn out. I do. Rough, and this will be rough, but we are going to do our best here. So we have different parts of our kidney. You'll remember we have our medullary and our cortical parts. We have cortical nephrons and we have juxtamedullary nephrons. Juxtamedullary nephrons are going to come down here, and they're going to be able to save a lot of water, really dilute urine. And the way that works essentially is you're going to have water, the ability for water to be reabsorbed into the blood as it goes down this descending loop. As we go down the descending loop here, we're going to have and increase concentration, osmolarity in our tubular fluid in our cells surrounding the tubules. And coming up, we're going to have that kind of decrease, but then going down again, we're going to have that increase. And depending on where we're permeable to water, water will follow the salts. Sodium chloride is responsible to about 600 here. Urea will be responsible for the remaining, so you'll see it come down to like 1200 here, and that's because urea is contributing to the difference in osmolarity. So that's countercurrent multiplication. I wish I could explain it better, but I still need to learn it a little bit better. Other than that, I think we covered everything that we need to, so I will probably talk to you in a week, and we'll go over respiration.